Assalamu alaikum, students. This is your third module of year 3, Neurosciences 2. And in the first three of your lectures, you have been given an overview of the nervous system. And Professor Asadullah has started with the autonomic nervous system, drugs affecting autonomic nervous systems. So today what I will be discussing with you will be the beginning of your antipsychotic drugs, and very important topic. And in this brief overview of the pathogenesis of schizophrenia, will be telling you something about the classification of antipsychotic drugs and describe the mechanism of action of these antipsychotic drugs and the main side effects of these antipsychotic drugs. It's something like a complex thing, and I can very well imagine that you will be doing all this without having a background knowledge of what psychosis is, what schizophrenia is. But inshallah, what we will be doing that in your tutorial classes, we will be giving you something about the, we'll be telling you something, and we'll be doing some work related to the pathogenesis, to the things, how does schizophrenia really comes into action, and what are the disturbances of the neurotransmitters at different receptors. The most important thing being that you need to know what is psychosis. Psychosis is a syndrome associated with many different psychiatric disorders, but is not a specific disorder in itself in diagnostic schemes. You need to have certain diagnostic tools, such as a former or name as DSM. It has many versions, DSM 1, 2, 3. So these versions help you to differentiate between the different types of psychosis. So this is, DSM stands for Diagnostic and Statistical Manual, which is designed by American Psychiatric Association. So with this background, that psychosis is a mixture of symptoms of delusions, hallucinations, disorganized speech, disorganized behavior, and gross distortion of reality. Here, a person's mental capacity, effective response, and capacity to recognize reality and communicate to others is impaired. Now, having entered into this stream, what is important, in my opinion, is that you must try to reactivate, to revisit your neurosciences module of year 2, and where you have been doing all the neurotransmitters, because we are doing psychosis, so we'll be dealing with mostly dopamine and serotonin. But as you all know, these two neurotransmitters do not affect solely by itself. Once they even act solely by themselves, they have their associated loop circuits with glutamate and other neurotransmitters as well, GABA. So once a receptor located in one part of the brain is activated, at the same time the same neurotransmitter inhibits the receptor located at some other place, which gives rise to the diversity of the symptoms of these things. So once you try to control one side, the other side gets out of the hand, and this is what the antipsychotic drugs, what we will be doing, you will be seeing by itself that how does these happen. So coming over to what is schizophrenia, is by definition a disturbance that must last for 6 months or longer including at least 1 month of delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. So, if we break down, if we deconstruct this syndrome of schizophrenia into symptoms, we have two sets of symptoms: the positive symptoms, delusions and hallucinations, and negative symptoms such as apathy, anhedonia, cognitive blunting, and neuroleptic dysphoria. Here is a complete list of the positive symptoms and the negative symptoms, and you can see very well that these are all very noticeable things. You can very easily diagnose these things. So if we go into the details of the symptoms, it will take some little time, but you must be knowing that, and you can refer to the book Stahl's book of psychopharmacology, which is there in your folder of books resources. That will give you a complete knowledge of what, because in a very short time it will be difficult for me to cover all the things, but I will make sure that these things will be covered in your flashcards and in your tutorials once you come back. So delusions are a type of positive symptoms, and these usually involve a misinterpretation of perceptions or experiences. A variety of themes, including referential, somatic, religious, or grandiose. Hallucinations, on the other hand, are a type of positive symptoms and may occur in any sensory modality. They can be auditory hallucinations, they can be visual hallucinations, olfactory hallucinations. Means the person may be saying that he is smelling something like a very sacred smell, or he is hearing some something behind, from something behind, leading him to do something. So these are what are the differences between delusions and hallucinations. So this is what the symptoms look like. So I would refer you to the chapter of schizophrenia in Stahl's psychopharmacology book if you are interested to learn more about the symptoms and how this happens. So having done that, we'll come straight to the classification of the antipsychotic drugs. Basically, what you need to know in the antipsychotic drugs is that there are two sets of groups. One is the typical antipsychotics, and the other one is the atypical antipsychotics. The typical psychotics, you have phenothiazine and butyrophenones, and in atypical you have clozapine, olanzapine, quetiapine, risperidone, ziprasidone, and aripiprazole. So in the slides to come, we'll be going into the details of what is a typical antipsychotic and how does it differentiates from an atypical drug, and what are the differences in the mechanism of action and their effects, and moreover their side effects also. So the typical and antipsychotic drugs, atypical antipsychotic drugs, mainly concern, if we are talking about both, we're talking about the D2 receptors and the 5-HT2A receptors, the serotonin receptors and the dopamine receptors. Typical antipsychotic drugs must be given in sufficient doses to achieve at least 60% occupancy of striatal dopamine receptors. Less than 60%, they won't have their effect. The atypical antipsychotic drugs are effective at lower dose means at lower occupancy of these receptors, D2 receptors, 30 to 50% because of concurrent high occupancy of striatal 5-HT2A receptors. From here, you can very easily get to the conclusion that the typical antipsychotic drugs are what targets only the D2 receptors, whereas the atypical antipsychotic drugs, in addition to dopamine receptors, they also have their effect on 5-HT2A receptors. So this is where the main difference lies. The other thing what you need to know, that the receptor occupancy between the two, in the typical it has to be more than 60 in order to have the antipsychotic effect, whereas in atypical antipsychotic drugs it can be between something 30 to 50%, because at this receptor occupancy the other receptor part of 5-HT2A is also helpful in reducing or in helping the patient overcome the neurotransmitters deficiency or overactivity in a specific receptor area. So if I can sum it up, the typical antipsychotic drug has effect on D2 receptors. They are competitive antagonists of dopamine receptors, typical antipsychotic drugs. Because their occupancy needs to be high, 60%, EPS, extrapyramidal symptoms, occurs if the D2 receptor reach 80% or more. So there is a very small or a very narrow window between 60 to 80%. So if the receptor percentage, occupancy percentage goes to up to 80%, you have the extrapyramidal symptoms, which are very much analogous with the typical antipsychotic drugs. The other thing is that the typical antipsychotic drugs with the high potency bind to D2 receptors but with high affinity. There's a group of typical antipsychotic drugs which binds with D2 receptors with high affinity and have higher risk of extrapyramidal symptoms such as haloperidol and fluphenazine. So these are the typical antipsychotic drugs which have a high affinity to D2 receptors and give rise to a higher risk of extrapyramidal symptoms, whereas the other typical antipsychotic drugs with low potency have less affinity for D2 receptors and tend to interact with non-dopaminergic receptors, resulting in more cardiotoxic and anticholinergic adverse effect, including sedation and hypotension. So first we talked about the difference between the typical and the atypical. The typical being solely related to dopamine receptors, whereas the atypical one, in addition to dopamine, have got an effect on 5-HT2A. Now, coming over to the typical ones again have two sets, one with high affinity to D2 receptors and the other one with less affinity to D2 receptors. The one with high affinity to D2 receptors got a higher risk of extrapyramidal symptoms, and the one with low affinity to D2 receptors has the other side effects from cardiovascular system, including sedation, hypotension, and being cardiotoxic. Coming over to the conventional first generation typical antipsychotic drugs, what are these? The D2 antagonist with antipsychotic efficacy and also have other binding sites responsible for the side effects. So if you can see, the main thing is that this is a D2 receptor antagonist, a competitive D2 receptor antagonist, but apart from having this D2 receptor, it has many other sites like M1 receptor, so on and so forth, which give rise to the other unwanted effects, like if you give D2 this typical antipsychotic drugs, the main side effect will be either it will have a blurred vision, a dry mouth, being constipated, and all this is because of the N1 receptors. Similarly, you have H1 receptors over here and the alpha 1 receptors, which can also exert their effect. So if you remember the last slide, we tell you something about being cardiotoxic, having something like problems with cardiotoxic effects, and hypotension, postural hypotension, which is because of this alpha 1 receptors, and sedation because of this H1 receptors. So you can rationalize your argument of the side effects by going down to the receptor or the molecular level because of these receptor sites. Whereas the atypical one has got two things. First, the dopamine receptor site has what? There it was a competitive antagonist in the typical one. Here in atypical one, it is a D2 partial agonist, right? In a moment we'll be telling you about what partial agonist means, and you must be knowing that from your background knowledge of journal pharmacology. The other one is that it has got this 5-HT2A, right? So this is a typical, and this being an atypical. So you can have something of this sort in your exam, and you will be asked to differentiate between a typical one or a atypical one with their side effects and so on and so forth. So many questions can be built up with this thing. So what does partial agonist do? Partial agonists have the intrinsic ability to bind to receptors in a manner that causes signal transduction from receptor to intermediate between full output and no output. Thus, many degrees of partial agonism are possible between two extremes. Full agonist, antagonist, and partial agonist may cause different changes in receptor conformation. D2 partial agonism render an atypical antipsychotic may stabilize dopamine neurotransmission in a state between silent antagonism and full stimulation. So it means it does not completely inhibits, as you can see from here. This is the normal working of dopamine, right? Once it binds, you get the full response. Once an antagonist is bound, dopamine antagonist, it gives you very minimal response, rather no response. But with a partial one, you have a semi-response. So this diagram will help you understand between this white part and this complete part. Atypical antipsychotic binding properties, they have many more atypical, have mixtures of pharmacological properties beyond antagonism of 5-HT2A receptors and D2 receptors. They interact with multiple other receptor subtypes for both dopamine and serotonin and have effects on other neurotransmitter systems as well. Some of these multiple pharmacological properties can contribute to therapeutic effects of atypical antipsychotics, antidepressants, antimaniac, anxiolytic, whereas others can contribute to the side effects of being sedative, hypnotic, and cardiometabolic effects. So, if you see the spectrum of the receptors, you can very well imagine the diversity of these atypical ones. So no two atypical antipsychotic drugs are alike, right? Each one has some unique characteristics. Now, I know what questions is coming into your mind. So do we need to remember all the differences between the atypical ones? My answer could be yes and no as well. Yes, because if you want to have a good grasp, you must know, because we cannot define boundaries over here. But we can tell you what is minimum required. The minimum required is that you must be able to, number one, differentiate between a typical and a typical antipsychotic, between the typical with high affinities and with low affinities, and in the atypical ones you need to know their effects, number one. Number second, you need to know the characteristic things of a few, and that few you can take as a reference from what we will be covering in our lectures, the drugs what we will be covering in our lectures. So atypical antipsychotics, aripiprazole and cerebrazine, have greater efficacy for non-psychotic mania, whereas potent antihistamine actions of clozapine, quetiapine and olanzapine are the other ones which are marked in this antihistamine effect. Now, just a quick revision of the four main areas: the mesolimbic ventral tegmental area to nucleus accumbens, which increases. This is the one. This is a simple recap. I can just skip also this because of the time constraints. I suppose you can just go through this because this is something what you already know, covered in your year 1, year 2 basically. So what you need to know that in the overactivity of mesolimbic system gives rise to delusions, hallucinations, or so-called positive symptoms of schizophrenia. The problem here is that there is too much of dopamine, right? So mesolimbic, positive symptoms; mesocortical pathways give rise to negative symptoms. Mesolimbic to positive, mesocortical to negative symptoms. Mesolimbic is because of too much dopamine. Here is in the mesocortical there is too less of dopamine. This is what the basics what you must know, because once we will be giving here dopamine, it will tend to aggravate the situation. Here we need to block dopamine. Here we need to promote or to give dopamine, right? We need to do certain changes in the neurotransmitters transmission so that the dopamine is increased in mesocortical area. The other ones, the substantia nigra, it is responsible that, remember that dopamine suppresses acetylcholine, and we'll be just going back to this. So what if we are treating this, the dopamine hypoactivity can cause Parkinson-like movements like rigidity, bradykinesia and tremors, akathisia and dystonia. What nigrostriatal pathway is responsible? Is responsible for coordination of voluntary movements. It accounts for 75% of dopamine in the brain. So dopamine receptor, D2 receptor blockade, is responsible for extrapyramidal symptoms. This pathway is involved in movement regulation. So nigrostriatal pathway being responsible for this extrapyramidal symptoms, whereas the tubero and fundibular system is from hypothalamus to pituitary, inhibits prolactin secretion from anterior pituitary. So you can imagine what could happen if this tract gets disturbed. Now, quickly going over to some of the mesolimbic dopamine pathway, which is responsible for the positive symptoms. In untreated schizophrenia, mesolimbic dopamine pathway is hyperactive, means there is more of dopamine. This leads to positive symptoms such as delusions and hallucinations. You see, all sort of olfactory and visual and auditory hallucinations coming up, shown in the picture. In a treated patient, administration of D2 antagonist with conventional antipsychotics blocks dopamine, which reduces hyperactivity in this pathway and thereby reduces the positive symptoms. So, if we block these receptors, like what we have done over here, so the dopamine could be excess in this synaptic cleft, but it will not be able to exert its effects because of the receptor blockade, and the positive symptoms will be reduced. This in part what we are covering, the pathophysiology of schizophrenia, or whatever the pronunciation could be. It's either schizophrenia or schizophrenia. So if D2 receptor and mesolimbic systems are blocked, then it also blocks the reward mechanism, leaving patients apathic, anhedonic, lacking motivation, interest and joy from social interactions, like negative symptoms of schizophrenia. Antipsychotics also block D2 receptors and mesocortical dopamine pathway, where it is already deficient in schizophrenia, and this worsens negative symptoms and cognitive symptoms. Typical antipsychotic can cause neuroleptic induced deficit syndrome, as like negative symptoms produced by schizophrenia. So what the problem is that you are able to treat the positive symptoms, but in the bargain the negative symptom gets worsened. Why? Because the dopamine, which is less in the mesocortical area, gets further reduced, and you have to wait for a minute in order to know how does that happens, because of the concurrent glutamate and the GABA neurotransmitters, right? So till now, what we have covered the D2 receptors and the mesolimbic system. So in an untreated patient, the dopamine is in excess in the mesolimbic area, giving rise to hallucinations. Once we block those receptors with dopamine antagonist, like typical antipsychotics, it relieves the positive symptoms, but in the bargain the patient gets a worsening of his negative symptoms. At the same time, the patient can also get neuroleptic induced deficit like syndrome, in which there is exaggeration of all the effects, and that is an emergency which needs to be treated by dantrolene, which is something like which counters the effects of the excessive blockage of the dopamine. And the effective symptoms of the ventromedial. So administration of a D2 antagonist could further reduce activity in this pathway, and this potentially worsens them. Nigrostriatal dopamine pathway and D2 agonist. This pathway is unaffected in untreated schizophrenia. But when we block the D2 receptor with a conventional antipsychotic, it prevents dopamine from binding and can cause motor side effects that are often collectively termed as the extrapyramidal symptoms. And the long-term blockade of D2 receptors and nigrostriatal dopamine pathway can cause upregulation of the receptors, which leads to a hyperkinetic motor condition, which is known as tardive dyskinesia, in which there is repeated protrusion of the tongue, facial grimaces, chewing, as well as quick jerky limb movements. So tardive dyskinesia is an exaggerated form of the extrapyramidal symptoms, which is caused by the upregulation of receptors due to prolonged blockage of the nigrostriatal dopamine receptors. The tubero and fundibular dopamine pathway and D2 agonist, how do they act? This pathway projects from hypothalamus to pituitary gland and is normal in untreated schizophrenia. So, but what happens with the treatment? D2 antagonists reduce activity in this pathway. This causes prolactin levels to rise, which is associated with side effects such as galactorrhea and irregular menstrual periods. So by now what you have been noticing is that we are slowly and gradually touching upon the side effects of the antipsychotic, especially the typical antipsychotic drugs. So this can lead to extrapyramidal symptoms, tardive dyskinesia, can lead to galactorrhea, irregular menstrual periods, so on and so forth. There's a reciprocal relationship between dopamine and acetylcholine in nigrostriatal dopamine pathway. Dopamine neurons in nigrostriatal dopamine pathway have postsynaptic connections with a dendrite of the cholinergic neuron. In normal setting, dopamine suppresses acetylcholine activity in normal settings. Antagonism of D2 receptors on the cholinergic dendrite results in acetylcholine excess. So the brakes are now removed, so there is a acetylcholine excess, and it also gives rise to the extrapyramidal symptoms due to relative dopamine deficiency and a relative excess of acetylcholine. So this is what the D2 antagonism and anticholinergic agents. So how can we overcome them? So if the D2 antagonism is also associated, has an associated feature of anticholinergic agent. If anticholinergic properties along with D2 blockade in typical antipsychotics, this will reduce the anticholinergic effects and thereby help in lowering the chances of extrapyramidal symptoms. So normally dopamine has got an inhibitory effect on acetylcholine in nigrostriatal dopamine pathway. Once we give dopamine antagonist, it removes that brake, there is an acetylcholine excess. So a remedy is that we give a typical antipsychotic with associated anticholinergic properties so as to lower the chances of 5-HT2A receptors. Okay, this is what we have covered, I suppose. Now going over to 5-HT2A receptor antagonist makes an antipsychotic atypical and low in giving rise to extrapyramidal symptoms. Normally 5-HT inhibits dopamine release. Antagonism of 5-HT2A receptors disinhibits dopamine release, causing dopamine release. Thus dopamine compete with SDA for D2 receptors and reverse inhibition there, as D2 blockade is thereby reversed. So SDAs cause little or no extrapyramidal symptoms or tardive dyskinesia. Okay, now too much of receptors, I suppose, and the neurotransmitter interaction. Now let's come up to the things, real things of these schizophrenia. We can summarize that, I suppose, in the end, because we are really getting hard on the time. The mesolimbic and the mesocortical pathways, which are responsible for positive and negative symptoms, may be involved in aggression and violence. Agents targeting much more than 60% of D2 receptor occupancy in these pathways could reduce these symptoms. Orbitofrontal cortex and amygdala play a key role in impulsive aggression, which could be relieved by targeting much more than 60% of D2 receptor occupancy. Affective symptoms may contribute to violent behavior, are mediated by ventromedial prefrontal cortex and could potentially be treated with mood stabilizers, which we will be covering once we will be doing the treatment of bipolar disorders. So that we will be doing this one. Finally, instrumental aggression and violent sociopathy may be mediated by dorsolateral prefrontal cortex and may be best managed with behavioral strategies including seclusion and incarceration. Now, this slide, what I have put in over here is with the purpose that you need to know the overall management layout. So, it's not only with the drugs, it's also very much done with behavioral strategies. So, it's a holistic management, it's not just related to the. This is what I was talking to you about the summarize. Blockage, remember I've shown you the alpha 1 adrenoreceptors, the typical ones. What they cause? They will cause dizziness, orthostatic hypotension and reflex tachycardia. Blockage of D2 receptors will help in relieving the positive symptoms of schizophrenia, but their main side effect is extrapyramidal effects and elevated serum prolactin levels because of the involvement of tuberoinfundibular pathway. Blockage of dopamine D4 receptors, elevation of negative symptoms of schizophrenia and increase in incidence of extrapyramidal effects. Blockage of H1 receptors causes drowsiness and increase in appetite and weight gain. Sedation may be observed, may be considered a therapeutic effect with a typical antipsychotic administered for acute psychosis. Blockage of muscarinic effect will muscarinic receptors will give rise to blurred vision, constipation, dry mouth and urinary retention. Blockade of serotonin 5-HT2 receptors will help in alleviation of the negative symptoms but can give rise to anxiety and insomnia. So this slide could serve as a reference for many questions. We can give you a scenario with these side effects and ask you about the receptors involved. We can give you the receptors involved and we can ask you about their therapeutic effects. So keep into mind that this one is a bit is a thing which you need not only to swallow but also to remember. Now coming over to the drugs, haloperidol, high potency and widely used, highly lipid soluble and protein bound. They have a large volume of distribution, extensively metabolized by the liver, bioavailability of about 65% after an oral dose and excreted in urine. It has a longer clinical duration of action as is evident from plasma half-life, has fewer autonomic effects but greater extrapyramidal effects. Clozapine, first of the new generation of antipsychotics, which is atypical one, decrease risk of extrapyramidal effects and effective for negative symptoms of schizophrenia. Associated with agranulocytosis, therefore requires weekly blood samples for CBC. Mostly associated with sedation, weight gain and increased liver enzymes. So again, questions can be framed. So clozapine, can you give it for to relieve the positive symptoms, and vice versa? Haloperidol, can it be given to treat the negative symptom? The answer should be no. It will aggravate. And why it will aggravate? The answer you got is once it blocks the D2 receptors in the mesolimbic part, its blockage in the dorsolateral and ventromedial prefrontal cortex will result in aggravation, means the dopamine which is already deficient there will be further reduced. Why? Because of the glutamate GABA dopamine interaction of the neurotransmitters. Risperidone, which is available in regular tabs and intramuscular depot forms. Now, what is intramuscular depot forms? Normally, an intramuscular injection when given exerts its full effect within hours, within an hour, 2 hours, maximum 3 hours. But once we give depot forms means it is based in an oily preparation of a sustained release part. It releases slowly. So the frequency of the injections is reduced, either given over 3 weeks depending upon the substance use. So 3 to 4 weeks apart, the injection can be given if you are using a depot forms. But all oily preparations, they need to be given by deep intramuscular injection. Functions more like atypical, increased extrapyramidal side effects, which is dose dependent. Again, side effects of weight gain, less sedation, and orthostatic hypotension. Most likely atypical to induce hyperprolactinemia. So that is what we were discussing, that no two atypical antipsychotic drugs are alike. Quetiapine causes increased levels of liver enzyme, may be associated with weight gains, though less seen than olanzapine, may cause hypertriglyceridemia, hypercholesterolemia, hyperglycemia, which is less than olanzapine. So olanzapine, which we are going to go over to the next one, increasing fasting plasma triglyceride or increasing insulin resistance. Coming over to the end, towards the end, the antipsychotic adverse effects of tardive dyskinesia, neuroleptic malignant syndrome, extrapyramidal side effects, alpha adrenoreceptors blockade, muscarinic cholinergic receptor blockade, and endocrine and metabolic disturbances. So main side effects, and you by now you must be in a position to identify the receptors and their respective areas and the neurotransmitters associated with this. So once you are giving antipsychotic drugs, monitoring on the metabolic highway, first, increased appetite, there will be weight gain, can lead to elevated body mass index, and patient can go into obesity. Second, atypical antipsychotics can cause insulin resistance by an unknown mechanism. This can be detected by measuring fasting plasma triglyceride levels. And finally, atypical antipsychotics can cause a sudden onset of diabetic ketoacidosis or hyperglycemic hyperosmolar syndrome by unknown mechanism, possibly including blockage of M3 cholinergic receptors. This can be detected by informing patients of symptoms of diabetic ketoacidosis and by measuring fasting glucose levels. So this is what you need to be taking along with you. So the take-home points, you need to be clear on the diagnosis when you are treating, and you need to be aware of the comorbid diagnosis when you are selecting an agent to treat. Often can get two birds with one stone, but the other way is also very common. Select the agent based on patient history and current symptom profile. Monitor the efficacy and tolerance. If the patient does not improve, step back, rethink about the diagnosis. Keep an eye on drug-drug interactions. Most important. I'll give you one task. It's a saying, it's not a saying, it's an observation. It's not even an observation, it's a fact that once you start with an antipsychotic drugs, in order to get the full effects of that drug, the doctor and the patient both have to wait for a couple of weeks. It is not an instant start, but it takes time. What is the reason, or what is the rationale that a person or a patient or a physician has to wait for time, 3 weeks up to 3 weeks, in order to get the full effects of these antipsychotic drugs? So within 3 weeks, The patient might be improving, the patient might not be improving. So you need to wait. And the other most important thing what you need to know and keep in mind of the drug-drug interactions, because this is a very highly lipid soluble drug with a very wide volume of distribution and a very long half-life. So even if you stop the treatment, the patient will be giving you the effects of the drugs for some time. So with this, I will close my lecture, and I will be available on the Zoom link tomorrow at the designated time for your queries to respond, and if possible we'll go through this lecture again over there. Best of luck. Hope you are enjoying your vacations. So all my blessings to you for a very spirited Ramadan and preparations for your Eid. Thank you so much. Khuda Hafiz.